So we can think about any obstruction at the aortic level, aortic stenosis, or LVOT obstruction, HOCM, or we can see this pansystolic murmur. In which condition we see? MR, or other causes of pansystolic murmur? TR, okay. Any other? VSD, okay. Pansystolic murmur. Even in MVP, what kind of murmur you see?
It's a pansystolic.
It is basically systolic murmur, mid to late systolic murmur. So, Major Sridhar, how we differentiate whether this murmur is of AS, HOCM, MVP, or MR? What do we do?
So we do some dynamic auscultation.
Okay.
So, dynamic auscultation, like all the right-sided murmurs increase with the inspiration, and left-sided murmurs increase with expiration. So then we also do other murmurs like Valsalva, hand grip, squatting positions.
Okay.
All other murmurs increases on squatting except HOCM and mitral valve prolapse.
Display the slide. So, dynamic auscultation, first respiration, right-sided all murmur increase, except there is one sound, which is pulmonary click, which decreases. Otherwise, all murmur on right side increases with inspiration and left increases with expiration. And with exercise, MR, AR, BSD murmurs, when we make the hand grip, after load, we increase the after load, then these murmur increases. And all stenotic lesion, they increases with isotonic and isometric exercises. Then position. Most murmurs, all murmur except HOCM and MVP. Just remember this. On standing, all murmur diminish except HOCM and MVP. And in squatting, it behaves in the opposite way. And we also do Valsalva. Basically, during strain phase of Valsalva, all murmur diminish except HOCM and mitral valve prolapse. So,
in our patient, his murmur increased in intensity with Valsalva strain phase and on standing, and decreased in supine position and on squatting. Systemic examination, respiratory, abdominal, and CNS system were essentially normal.
So, Major Ashok, summarize the case.
Sir, 49-year-old male, sir, non-smoker and non-alcoholic, negative family history, sir. Presented with complaint of palpitation, angina, dyspnea, and pre-syncope, sir.
Dyspnea. First symptom was dyspnea. Then?
Angina, sir. Then palpitation and then pre-syncope in 6 months, sir. There is also a past history of multiple admission.
Decompensation, okay.
Decompensation, sir.
Okay.
And sir,
also
general physical examination
at that time with heart failure.
Sir.
Okay.
And sir, general physical examination, sir, there are.
And there is one more important. He underwent angiography also in past.
Sir, there are, sir, double impulse are there, sir.
And just start from the pulse. What type of pulse we see? We have seen in that case.
Triple and
biped jerky pulse.
Yes, sir.
Okay.
And also, sir, systemic examination, sir, S4 and murmur, sir, which increased during squatting.
Okay. Major travel
increased during squatting, sir.
So, what do you think from this? What is the diagnosis?
With the history of dyspnea being the first symptom, mostly in HOCM, there is a classical history of dyspnea which occurs initially, and also with the history of angina, pre-syncope, and palpitation, with the examination finding suggestive of biped pulse, along with the triple type of effects, and palpable S4, and also with the murmurs like ejection systolic murmur in the left lateral sternal border, and also pansystolic murmur at the apex. Most likely it is a left ventricular outflow tract obstruction likely to HOCM, which is leading to mitral regurgitation.
What?
Which can lead to mitral regurgitation because of the anterior.
Okay, so there are two murmurs basically, and this profile is suggestive of some obstruction at the LVOT along with some murmur of mitral regurgitation. So, what clinical diagnosis comes in your mind?
Sir, it is a cardiomyopathy which initially
What kind of cardiomyopathy?
hypertrophic cardiomyopathy,
Hypertrophic, but there is obstruction also. So we will say
obstructive
hypertrophic obstructive cardiomyopathy, or we can have hypertrophic cardiomyopathy with the obstruction at the LVOT level. Okay. So why MR in this case?
So,
If we think about HOCM, why murmur of MR?
so whenever in HOCM there is a reduction in the outflow tract of the left ventricle, sir, where there is a increase in the pressure which due to there is an aortic pressure which increases, thereby there is a venturi effect which causes movement of the left anterior motion of the mitral leaflet, sir. So which causes there is an obstruction and thereby there is a delay in the mitral valve closure of the mitral.
Can you explain? Cause of MR in HOCM?
Sir, in HOCM, there is a functional anterior septal motion of the mitral wall. This occurs due to the pressure gradient, sir. Whenever the
One thing is you can say just venturi effect, and the other.
Sir, it is due to the left ventricular increased pressure.
So basically in HOCM, what basically HOCM is, there is hypertrophy, there is uncontrolled hypertrophy or fibrosis, we can say. Okay, so this is pathology. Along with that, there are some abnormality in the papillary muscle also. So papillary muscle can be abnormal position. That can lead to MR because they are attached to the anterior mitral leaflet and posterior mitral leaflet. The papillary muscle can be abnormal. Then as such, in these cases, sometimes as such, an anterior mitral leaflet is abnormal, that is elongated and abnormal. So because of that also MR can occur in HOCM. So Spondylitis Abhishek, as we are saying first differential diagnosis, we are keeping HOCM and patient had angina. So can you explain in HOCM why angina?
So there is the discordance between the angina usually occurs on exertion. So there is discordance between the.
No, why in HOCM angina occurs?
So there is because of the decreased ventricular filling, so which can lead to subendocardial ischemia, and also there is discordance between the muscle and the oxygen supply, which can be present.
So basically demand and
Demand
supply
perfusion
mismatch
mismatch, sir.
because of hypertrophy of muscle. Okay. Other causes?
So second can be the subendocardial ischemia can happen because the ventricular filling is reduced because the cavity size is reduced.
They have some microvascular dysfunction in the coronaries, then associated coronary anomalies. Then coronaries can go between the myocardium, which is called myocardial bridging. So all these factors can lead to angina. Next slide, please. So in our case, we thought of HOCM with the MR, and other is just display the previous slide, please. Then valvular heart disease, AS with Galabardine phenomena, because we had one murmur at apex and one is ejection systolic murmur. So what is Galabardine phenomena? Basically, Galabardine phenomena is seen in aortic stenosis. One is ejection systolic murmur, which one component of murmur, high pitched sound are transmitted to apex. So you can hear like MR murmur, but it is in the late phase of the systole. Next, please.
On evaluation, his hematological and biochemical parameters were essentially normal.
ECG, anyone please interpret the ECG? Pankaj? Shridan?
So there is strain pattern, sir, in one AVL.
First, see the rhythm. Rhythm, see heart rate. Describe from that. What is the heart rate? He has bradycardia. Heart rate is less than 50. Then other thing, axis.
No, access is normal.
Axis is almost normal axis. Okay. Then he has LVH. Then there are some
Strain patterns in from
repolarization of normality in the form of inverted deep T waves in the almost in all the leads, basically main in the pericardial lead and lateral leads, one and AVL. Next slide, please. Any radiological resident? What is it seen in X-ray?
Radiograph chest posterior anterior view, borderline left ventricular type of cardiomegaly is seen. So there is prominence as well as syphilization of the pulmonary vessel seen, which can be due to the stage 1 pulmonary venous hypertension.
Which grade?
Grade 1, sir.
Grade 1. And what happens in grade 2?
So grade 2, we will have curly V lines and we will have peribronchial cuffing. And in grade 3, we will have alveolar opacities with pleural effusions.
Okay, so this has a PVH grade 1.
Sure.
Next slide. So we did echo in this case. We can see the significant concentric hypertrophy here. You can see the significant concentric hypertrophy when posterior wall is also thickened, and he had systolic anterior motion. But anterior mitral leaflet is moving. It's systolic. It touching the septum. Next slide. So this is color Doppler. We can turbulence at the LVOT, and there is we can see the MR jet here. Next slide. So we put up the continuous wave Doppler and we took the gradient. So resting gradient was 45. Basically, difference between the pressure between the LV and aorta was 45. And provoked with Valsalva, it was 75. So we can see this dagger shape shaped in the continuous wave Doppler. Next slide, please.
On further evaluation, his angio was normal. Genetic study revealed TN troponin C1 mutation. Holter study was essentially normal.
So any radiology resident? MRI?
So these are representative short axis as well as long axis white blood sequences.
So what is this?
So this is myocardial wall thickening seen in the
And
intervention.
what is this scene?
Sir, this is the blood, sir. Sir, so there is
And this is?
sir, this is the dilated left atrium.
Okay.
And we can see there is interventricular septum thickening in the subaortic area, leading to LVO2
Basically,
obstruction as well.
septum and posterior wall both are seen thickened here. Here is cut section, cross section. We can see this.
Sure.
And what else we see in cardiac MRI in such cases?
Sir, in cine images, we look for the systolic anterior motion of the mitral wall.
With gadolinium, what do we see?
Sir, we will see LG patchy and mid-ventricular enhancement, which can be cystofibrosis.
Okay. Next.
We arrived at the final diagnosis of hypertrophic obstructive cardiomyopathy with normal LV function, PVH, no PAH, presently in NYHA class 2, in sinus rhythm with no evidence of infective endocarditis and normal coronaries.
So how will we approach this case? How will we manage this case? Anyone from the final year? Scholar leader Robin?
Sir, coming to the lifestyle management, sir, will tell patients not to go for strenuous activities or exercises, sir.
So what can happen with the stainless?
Sir, the murmur can increase.
Okay, murmur is one thing. Clinically, what will happen?
Sir, he might go into decompensation, sir. They can be heart failures.
He can have syncope. Any other thing?
Sir, sudden cardiac death, sir.
Sudden cardiac death on exertion because of LVOT sudden obstruction, and they can have arrhythmia on exertion. Okay.
Sir, now coming to the medical management, sir, the aim would be to keep the preload, afterload high, sir, and to keep the force of contraction low, sir.
Okay.
So we'll give patients beta blockers, but we'll not give patient diuretics or venodilators, sir, because those venodilators or diuretics might reduce the preload, sir.
Great. Good.
Then, sir, we'll come to the definitive management, sir.
Then there is one line: prevent sudden cardiac death. What can we do with the lifestyle modification? What else we can do?
ICD
Yeah,
implantation.
we can go for
ICD implantation.
ICD implantation. Okay.
And
Then
sir, coming to the definitive management, sir, we can go for the alcohol ablation or
alcohol ablation of what?
sir, of the septum, sir,
Septum.
Yes,
Okay.
or the myectomy, sir.
Surgical myomectomy, just to relieve the left ventricle outflow tract obstruction. So basically, medical management as present is aimed at first is just to prevent the symptoms and prevent the sudden cardiac death, as these is one of the common cause of sudden cardiac death. So one is